Hey guys, welcome to Man Medicine, where we talk about how men can optimize their health and escape the collapsing U.S. healthcare system. All right, well, what do I mean by that? The collapsing U.S. healthcare system. What do you mean the healthcare system's not collapsing? We have the best healthcare system in the world here in America. I have seen some very significant changes in the last 20 years of being a physician. It'll be 23 years for me here coming up this May, actually. And it has a lot to do with, it reflects what's happening in our population and in our society in general. So I want to talk about that today. I want to touch on some of the things that I think are collapsing the U.S. healthcare system. It's not just one thing, obviously. It's a lot of things. But at the end of the day, not to be a downer on this, there's short of like massive restructuring of our society and the way that we operate and the way that we look at health. I don't see this ship turning around. All right, we're on the Titanic, and we've got a lot of folks in local and federal government, and even in the private sector, rearranging the deck chairs as best as they can. But at the end of the day, the ship is going down. So what I want to show with you guys today, this is I just took a screenshot of my computer display when I went to work one day many months ago. And I arrived right in the emergency department. I was about to start my shift, and this is what the board looked like right here. So I've cut out all the names, obviously, and the dates, and the ages and the gender of the the individuals here. But there's just a few things I want to highlight here that reinforce what I'm about to share with you in terms of the collapse of our system. So obviously you can see the complaint there that the individual has checked into the emergency department with or been brought there by ambulance for. On the far right, the check marks are the people that are actually in a room, and the ones that don't have a checkbox are in the waiting room, or they're like actively being triaged. So we're waiting to bring them back to be seen. So at the time when I took this picture, there was one doctor in this department that was trying to take care of all of these people. There are periods of time in a lot of medium and smaller sized emergency departments where there's only one doctor on at a time. Most places have a period of time when there's two, or maybe there'll be like a doctor and a PA, or a doctor and a nurse practitioner. And that's in most of these medium, like small, semi-rural, suburban emergency departments that you'll run into. Obviously, if you work at a big level 1 trauma center, I mean, I've worked at centers like that where we've had 5, board certified emergency docs working at one shift. And that's actually really nice because things can get pretty busy there. But what I'm seeing now is that level of busyness and that kind of acuity that I would see 10 or 15 years ago at a level 1 trauma center is now starting to spill into these smaller emergency departments that don't have the means to take care of people that are that sick, or certainly not more than like 1 or 2 of them. So anyway, back to this list here. You'll notice after the complaint, some of these individuals have a little airplane symbol by them. And what that stands for frequent flyer. Okay. Now, a frequent flyer is somebody who utilizes the emergency room on a regular basis, far in excess of like the general population. So these are people that we see over and over and over again. Some of them I'm on a first name basis with because I see them so much. It doesn't mean, by the way, that these people are using the emergency department inappropriately. Okay. I want to make sure that I state that because it's true. Now, some people, and a lot of people, clearly, they come to the emergency room for things that are not emergencies. And they know that they're not emergencies, but they just do it because it's convenient, or, the appointment that they're going to get with their primary care doctor is 2 days from now, and they just can't wait for whatever this problem is. So we still see a lot of those people, but most of these people that are labeled as frequent flyers, they're frequent flyers because they're really sick. And they get really, really sick, like repeatedly over. So we see them back, and it's for legitimate reasons. All right, it's not just because they're abusing the emergency room system. Although, God knows, there's plenty of people that do that. So that's just in case you're wondering. That's what that airplane thing is. The number next to that is their triage category. The higher the number, the more severe the triage nurse thinks that their complaint is, or the sicker they they look when they first arrive. So obviously, if you're a 1 or a 2, that's a big deal. If you're like a 5 or 4, you're not necessarily as sick, and presumably you can wait. But that's not always the case. There are lots of 4s and 5s that rapidly turn into 1s. That's just how it is in emergency medicine. The thing I want to draw your attention to the most is the numbers under where it says TT. Now that's total time in the emergency department in hours. So look at some of those numbers. Now the top one there, this individual had been in the emergency department for 245 hours and 11 minutes. Now, without revealing too much, this was an elderly person who could no longer take care of themselves, had dementia, and the family just dumped them in the emergency department and refused to take them home. And they also had severe behavioral outbursts. They were violent, which happens sometimes with people with advanced dementia. And there were no skilled nursing facilities or nursing homes that were willing to take this person in that condition, which I understand. So they needed geriatric psychiatry, which we don't have. There's a massive shortage nationwide for psychiatric services for not just geriatric people, but for children too. So this person is languishing in the emergency department, waiting for a bed or somewhere to open up, some sort of a facility where they can go and get the care that they need. The next person, 22 hours and 51 minutes. This actually was a heart attack. Heart attacks belong in the ICU or the CCU at a big hospital somewhere. They're at the time when I took this picture, and most days, this is important, most days that I work, there are no inpatient beds anywhere in the hospital. There are no inpatient beds anywhere in the local area, the county. And quite often, more days than not lately, there's not a single available inpatient bed in the entire state. So let that sink in the entire state. So I have sent people on airplanes to another state to be admitted to the hospital for various different things. The last one I sent had a severe kidney infection and was critically ill. I had to put them on an airplane and fly them to Idaho. I've done that to Northern California too. Not a single bed open in the state. So, and by the way, that's the new norm, by the way. This never used to happen. I'm going to talk about that too. We'll work our way down through here. There's another one, diarrhea. I've been there for 3 hours. Chest pain. This was this was another heart attack, full-blown, heart attack that we were treating in the emergency department. Could not find a cardiologist anywhere in the state that could accept the patient. Been there for 12 hours. Shortness of breath. This individual, that was a 2. This was a very sick lady who had a large pulmonary embolism. There's a blood clot in the lungs. Okay, this lady very easily could have died. 35 hours, she's there. The next one down, failure to thrive. So this is another elderly person with dementia who was chronically ill, who was driven to the emergency department by their family, dumped in the waiting room, and the family took off and would not answer their phone. And they can do that. They can do that legally. We refuse to take the patient home. So we're left with this individual who is a danger to themselves because they don't know who they are. They're confused. They have violent outbursts. And we have to sit on these folks, so to speak, and try to find a facility that can admit them and take them in. And that's extremely challenging these days. So 174 hours this person was there. And I'm not going to go through the rest of these. You can look at the numbers. But the point is, if you come to the emergency department these days, and this isn't just where I work, by the way. I have colleagues all over the country. This is just how it is these days in most areas. If you come into the emergency department and you're sick enough to need an inpatient bed, you may not have an inpatient bed at that hospital. You may not have one in the local area. You may not have one in the entire state, but you're too sick to go home. So what's going to happen is you're going to be in the emergency department. Now, this used to happen, this is not just with COVID. This used to happen when I worked at big inner city hospitals, level 1 and level 2 centers in Florida and places in Texas and Alabama. We boarded patients there at times, when there were no inpatient beds in the hospital. But it was never for these kind of lengths of time, and it was never in the numbers that I'm seeing now. And when I also worked in smaller community hospitals during that time, this never happened. It was extraordinarily rare to be boarding people, 10 years ago. But now it's commonplace. You can expect to stay in the emergency department a very long time these days. And we'll do our best to take care of you, but it's not the best place for you if you're critically ill once you're stabilized. You need to go to an intensive care unit, but there's no intensive care units that are available. And the reasons for this are long, and I'm not going to get into all of them. The COVID pandemic, or I should probably say the response, the poorly thought out response to the COVID pandemic has worsened these things. But it's exposed problems that were already present in the system. It's just now made them worse. So it's my opinion that we would still be heading in this trajectory if COVID had never happened, because the fundamentals that have led to this were there in the background even before COVID, came around. So COVID has just accelerated things. So, if you are interested, this is actually a really well done documentary. It's called Code Black, and I think it came out like 2013 or 14. So obviously well before the pandemic, and it follows a bunch of doctors in training at I think down at in LA County, somewhere down in Los Angeles. I think it's USC, the big emergency room down there, which is kind of where the whole specialty of emergency medicine was born. And it's a good thing to watch because it shows just how just totally overrun and crowded and totally chaotic one of these big inner city urban hospitals is. And it shows people, the waiting room completely packed, people waiting 12 or 14 hours to get seen because they have no other healthcare options. And that's true. Like, I've worked in places like that, and for many years actually in my career. But what you're seeing in this movie used to be, in my experience, isolated to these large urban centers. That's not the case anymore. This is now, sometimes even in rural emergency departments, you're seeing the same level of backlog, the same kind of chaos, and the volume of sick patients is just going through the roof. And there's a number of reasons for that. We're going to talk about that here in a second. But check it out, Code Black. I thought it was pretty good. And if you ever want to know what it's like to work in a big urban inner city ER, it's a good. It shows you. It's a good look at that. So ultimately, the U.S. healthcare system is going to collapse for the same reason that businesses collapse and countries collapse when one of those things is just the difference between supply and demand. So healthcare resources, there's a limited supply of healthcare resources, and they can be increased over time. But what's happening now is that the demand for healthcare is just rapidly, it's going to outstrip the supply because the population is just so sick, and there's no end in sight to this. The population there are no signs that we're getting healthier. We're just getting worse and worse and worse. And so the demand on the healthcare system is only going to go up. And it's going to skyrocket. It's already skyrocketing, but it's going to be much higher here in the future. So the United States and pretty much every other country in the world is going to have some tough decisions to make in the future about how they're going to manage the healthcare of their citizens. So what is the underlying cause, or what's one of the major underlying causes for this? In my opinion, it is the obesity epidemic. Obesity is absolutely, no pun intended, it is crushing this country in ways that are too many to talk about. But from the healthcare standpoint, people would always ask me, when I told them I was an emergency room doctor during this whole COVID thing last few years, they'd always say, "Oh man, how are things with COVID? How's it going in there? It's COVID." And yeah, obviously I was seeing a ton of COVID patients and a lot of sick COVID patients, and I was putting people on ventilators, but that was not what kept me so busy. What has kept me busy my entire career and is just skyrocketing is cardiovascular disease, so heart attacks. I'm seeing strokes. I see blood clots and PEs. I see sepsis, and I see all manner of complications from type 2 diabetes, skin and soft tissue infections. We're amputating toes, and then a lot of methamphetamines, and now these days, obviously, a lot of fentanyl. So a lot of like illicit drug related issues. So, which is the same thing that I was seeing before COVID. It's just now, it just every year, it just seems to be getting worse and worse. And there's a reason for that, is because everybody's getting fatter and fatter in this country. And obesity, all of those problems, with the exception of the substance abuse part of it, all of those, one of the root cause of many of those problems is obesity. Obesity is a major factor for cardiovascular disease. It is a huge risk factor for type 2 diabetes and all of its complications. So obesity is going to wreck the U.S. healthcare system. It's actively doing it right now. So here's a little glimpse into the future. So this from the New England Journal of Medicine: projected U.S. state level prevalence of adult obesity and severe obesity. This one, you can look this up if you want to. They have some really good maps in there, and they're color coded by state, so you can see where your state lands in terms of obesity. And obviously some states are fatter than others. The South is, you guys in the South are screwed. But I highlighted something here from the abstract, which conveys the point that I want to convey to you guys. And it says, the findings from our approach suggest with high predictive accuracy that by 2030, which is just around the corner, nearly 1 in 2 adults will have obesity in the United States. So 50% of U.S. adults will be considered obese by BMI. And you guys all know there are inherent problems with BMI. What I think is, if we use body fat percentage, this 50% number that are categorized as obese would be much higher, right? There's a lot of skinny fat people too that have very high levels of body fat, visceral body fat, but maybe are not quite so heavy that they have a BMI that lands them at 30 or higher, okay? So if you go by body fat percentage, my suspicion is that's going to be much higher. So 1 in 2 adults will have obesity. And then the prevalence of obesity will be higher than 50% in 29 states. So 29 states out of 50, it's going to be more than half the population is considered clinically obese. Just scary, okay? And it will not be below 35% in any state. So no state will have less than 1/3 of its population that is obese, okay? That's 7 years from now, okay? I think we're probably already there. I think we've gotten there sooner. I have no data to support that, but I'll just tell you that what I see at the emergency department is I see obesity rates way more than, it seems like it's way more than 50%. It's probably like 70%, if not higher. All right. So that's where we're headed, guys, 50%. Okay, obesity, according to this article. And in kids, it's absolutely horrendous. This is a Medscape article. 21 to 24% of American children and adolescents are overweight, and another 16 to 18% are considered obese. All right. So what do you think is going to happen to those kids when they're 40 or 45? Okay, so this is a huge problem, and it's not just a problem in our healthcare. Like, it's a problem society-wide. Society-wide. Like, there are massive economic consequences to having a 50% obesity rate. Your most productive years economically are usually like between 30 and maybe 55. That's when you're in the workforce. But if you're chronically debilitated from type 2 diabetes, cardiovascular disease, whatever, because you've been obese since you were 3 years old, for example, you're now not contributing to the workforce like someone who didn't have those kind of problems. And it's a huge, national defense issue. As a guy who, spent a career in the Air Force, the obesity epidemic is going to be a huge military issue. Already, there's huge numbers of young people in this country that are not eligible for military service because they're too fat. It's the only reason. They're too fat. So they can play Call of Duty really well, but they can't make it up a flight of stairs because they're too obese. This is an article here from Newsmax. It's just quoting a DoD study. This is pathetic. So Marine Corps is the least obese, as you would expect. Would expect you Marines to be the best. You're the least obese of all the services, but that's still 8.3%, okay, of the Marine Corps has a BMI of 30 or higher. 22% for the Navy. Well, sorry, guys, from the Navy. That doesn't surprise me. We should joke about you guys. But, the Air Force is we're right behind you there at 18.1%, and then the Army's at 17.4%. Now, in 2011, only 2.3% of the Marine Corps was considered obese. 9.4% of the Air Force was obese, so it's roughly doubled. And then only 6.4% of active duty Army personnel were considered obese just in 2011. So these numbers are going through the roof. And, you know, back in the day, if you got yourself fat and couldn't pass your PT test, you got kicked out. Well, we're at the point where they're going to have to start, if they haven't already, lowering standards and making exceptions and basically giving people fat waivers, which is outrageous. Because they just can't hold on to folks. So this is a huge problem. It's a huge problem across the country, economically, in the medical system, and obviously in the military as well. And the costs of this are absolutely huge. Here's this graph from an article that I pulled. Healthcare costs continue to rise faster than wages and inflation. You can see the chart here. Healthcare expenses are just going up and up and up, and they're not being matched by increases in income. So, healthcare expenses are bankrupting thousands and thousands of people in this country. And there's no signs that this is going to get any better, and there's no solution on the horizon that is going to undo this. And according to this article, they said $5.96 trillion per year is what our healthcare expenses are going to be by 2027, which is just around the corner. Okay, and healthcare expenditures are outpacing annual GDP growth. Okay, that's huge. So these costs, because we have the technology is amazing. Some of the stuff we do even in the emergency department with ECMO and all these sorts of things is absolutely amazing. The things that they do in the ICU, but the cost for these interventions is massive. And unfortunately, we're having a population that's getting incredibly sick, yet still has extremely high expectations for what the medical system can do for them. So, these folks come in sometimes to the hospital that are just complete medical train wrecks, and they fully expect that we can fix all of these problems and save their lives. And the fact is that many times we can't. We end up just putting a Band-Aid on it. I can't undo 40 years of bad decisions on your part, bad lifestyle choices that you've made in an ER visit or in one hospital stay. I mean, you got clogged coronary arteries, we can stent you, but again, that's just kind of a Band-Aid, for a problem that you have created for yourself, quite honestly, in most cases, not all. So, ultimately, I don't know what's going to happen here with these kind of expectations from the general public. I think, there's going to be a cry for government intervention. So essentially people will be appealing to the very same people that in many ways contributed to this problem in the first place in order to solve the problem. And I think we can probably predict how that's going to work out. And ultimately, I think we're going to have some sort of a healthcare rationing system in this country. It'll become increasingly socialized. That's my prediction. There's some problems with that. So the bottom line is, in my opinion, it doesn't matter what kind of healthcare system a country has, whether it's a completely socialized system like they have in Canada, and like the NHS system in the UK, or like in Sweden they have a big national health service. When you have a population that's as sick as what America's population currently is, and as sick as it's projected to be, I don't think there is a system that's going to be able to handle that without making major sacrifices in other parts of society. The United States is going to have to at some point make a decision between, do we want $13 billion aircraft carriers like the Gerald Ford that was commissioned recently? Do we want to spend $300 billion on 100 B-21 Raider stealth bombers, which are super cool, or do we want to make it so that people can afford their insulin? These are the choices that eventually are gonna that the government's gonna have to face, and society in general. So it's not going to be pretty. And speaking of not pretty, so I love this slide. I both love it and hate it, obviously, for clear reasons here. So this is a really telling graphic, and it's the number of physicians versus the number of administrators in the United States between 1970 and 2009. And I couldn't find the data post 2009, but I'm sure that curve has just continued to rise for administrators. So you can see, like, towards the late 80s, as healthcare became, as government started kind of poking their nose into healthcare a little bit more and creating more and more requirements, and insurance systems became more complicated, the number of administrators required to run these programs in the private sector and in public hospitals started to go up. So there's just, I mean, it's absurd, this massive increase in healthcare administrators, and you can see this tiny little inflection where the number of physicians, and I'm sure if you superimpose like nurses and CRNAs and stuff like that, it probably would mirror the physician graph. I haven't seen any data on that, but I imagine it's probably pretty close to the same. So what is it? 3,000% growth. Now, I would ask you, do you think that we have had a corresponding, if we had a 3,000% improvement in the healthcare system with all these administrative folks, have we had a 3,000% improvement in outcomes or in quality? We certainly haven't had a drop in cost. In fact, they have added to the cost tremendously. So this kind of bureaucracy is, I had to deal with this in the primary care world years ago, and it was onerous back then. And I can't even imagine, those of you that are primary care doctors these days, I mean, my heart goes out to you. You're saints, because I know the hoops that you have to jump through to deal with this massive bureaucracy just to do the right thing for your patient. Okay, but there are people that are doing very, very well in this system. It's not me. It's probably not you. This paper here is from JAMA Internal Medicine, January 2016. Compensation of chief executive officers at nonprofit U.S. hospitals. Okay, now I can imagine what it is for for-profit organizations, but in this particular study, they sampled a whole bunch of nonprofit facilities, and they found that the average CEO in our sample had a mean compensation of, $595,781 a year. Cool. Yeah. I'm sure they earn every penny of that. Yeah, I think I went into the wrong field. All right, guys. Well, that's enough doom and gloom. So what can you as an individual do about this? We know, and unless you've got an idea that nobody else has thought of, I don't see us turning this ship around. The Titanic is sinking. It's hit the iceberg, and now your job is to find a lifeboat. But you're the only one that can do that. So what I say at the beginning of all these videos for you guys is how men can optimize their health and avoid the collapsing U.S. healthcare system. So the way that you avoid the collapsing healthcare system is you do everything in your power to make yourself so healthy that you don't need it. Because once you get sucked into this system, if you have a heart attack, you have a stroke, you have a diabetic emergency, you have kidney failure, whatever, you are now sucked in to what Dr. Doug McGuff refers to, and I agree, as the belly of the beast. And you're probably not getting out at that point. You're going to become dependent on very expensive prescription drugs that you can't afford. Your quality of life is going to deteriorate, and it's very, very difficult to get out. So, ideally, from an early age, you got to take care of yourself. Don't be obese. If there's one thing I can tell you guys and recommend for you, probably the single biggest thing you can do for yourself, because again, the root cause of so many of these problems that I take care of in the emergency department and that are clogging and draining our system, one if not the major root cause of so many of those problems is simply obesity. All right. So, and God forbid, if you got an obese child, you need to fix that. I know that's easier said than done. If you don't know what to do, get help. All right, there's resources out there. Do not let your 5-year-old who's obese become an obese 25-year-old. Okay, it's going to destroy their life. please do something about that. And if you are starting to get obese or you are obese, you need to do something about it now. And the sooner you act on it, the better. Okay. Again, I appreciate that that's incredibly difficult. Obesity is a complex problem. It's not a matter necessarily of just eating too much and not moving enough. It's incredibly complicated. Get some help. Okay. This is one of the things that I do. There are many physicians out there that do it, but you don't even need a doctor. The information is out there. Okay, you've got a smartphone. That means you've got access to essentially every bit of knowledge ever recorded by the human race in all of its history on your phone. So maybe don't look at so many cat videos on TikTok. Go out there and find information on nutrition, health, etc. I don't know what the optimal body fat percentage is for health for the general population. My estimation, based on some limited research out there, is it's probably 10 to 15% body fat. Okay, that may sound completely unreachable to you, and maybe it is for some people, but I wouldn't sell yourself short. 10 to 15% is achievable. It may take a while, but you can get there if you apply the right knowledge and you do it for long enough. You can get there. 10 to 15% body fat used to be common. I mean, that was the norm. Look at old pictures from 100 years ago. The average body fat percentage now is above 30%. Things have clearly changed, but I would recommend 10 to 15% body fat. What's the leading cause of death for men and women in this country? It's cardiovascular disease. So obesity is definitely a part of that. But you know what? High blood pressure, hyperlipidemia, so cholesterol, despite what you hear from some of these knucklehead influencers out there, your lipids are very important. You need to really keep an eye on your LDL, ApoB. You need to be screened for lipoprotein A. All of these things are super, super important. Cancer prevention is huge. Now, cancer prevention doesn't mean you go get a colonoscopy now at 45 or you get your mammograms. Cancer prevention starts with good nutrition and lifestyle changes, so exercise. And quite frankly, what's one of the leading risk factors for cancer? It's obesity. So again, if you address the obesity part of this, many times the cardiovascular disease risk and the cancer risk goes along with that. So you can greatly reduce your chances of having both of those just by getting lean. Again, maybe 10 to 15%. I don't know what the optimal body fat percentage is. But that's probably, I think that's reasonable to say that. Minimize the amount of processed food that you eat. You've got to exercise, okay? And you've got to exercise, in my opinion, using some form of resistance training. You have to respect your musculoskeletal system. You have to stay physically strong. So when I ask some patients if they exercise, they say, "Oh yeah, I exercise like 3 or 4 days a week." Or what do you do? Well, I take my dog for a walk. Listen, that doesn't count in my opinion. That's not exercise. Walking is a means of transport. Okay, it's not exercise. And I understand if you're elderly, that may be all that you can do. But even in those cases, elderly people, no matter how debilitated they are, can do some form of resistance exercise. Again, if you don't know how to do that, there's resources out there. Just make some minimal amount of effort and you can find what you need, okay? And I think it goes without saying, for God's sakes, like, don't use meth. Don't get hooked on opiates. Do not smoke. It's shocking to me the number of young people I see in the emergency department where I work that smoke cigarettes. It's like there's just no excuse for it. You're a knucklehead if you're doing that. Even if you do smoke, you need to quit. Anyway, guys, that's all I have for you. Take care of yourselves. The system is collapsing. Do not look to anyone else other than yourself to be responsible for your healthcare. You are responsible for your healthcare. It's your responsibility to advocate for yourself when you see your doctor. And if you're counting on the government, if you're counting on your job or your insurance company or Kaiser, or Aetna or any of these big healthcare organizations, if you're counting on them to look out for you and to prevent you from being sucked into this medical system, then you're just fooling yourself. You've got to do it yourself. And my wish for you guys is that, barring like some unforeseen accident that you have no responsibility for, that I never have to see you in the emergency department for any of the common things that I just talked about that I see so many people for. So good luck, guys. It's going to get ugly in the next 10 or 15 years. And I hope I'll be retired by then. But you never know. You never know. So anyway, you guys take care. I will get you next time. All Man Medicine video and audio has been created and shared online for informational purposes only. This podcast does not constitute the practice of medicine or professional healthcare services of any kind, including the giving of medical advice. I am not your doctor. No doctor-patient relationship has been established. This content is not meant to be a substitute for professional medical advice and should not be relied upon solely for that purpose either. The only purpose of this content is to present peer-reviewed, research-backed health information for your consideration. As always, rely on the advice and guidance of your personal physician before undertaking any activity presented here, and if in doubt or not comfortable with said activity, practice discretion. Your health is your responsibility and not ours. Finally, I take conflicts of interest seriously. I accept no compensation whatsoever from any private corporations, including pharmaceutical or supplement companies. You can trust that if I recommend a medication, product, or service, it's because I genuinely believe in it and not because I'm being paid to endorse it.